Alrighty. Hello, everyone. I am so excited to see you all here. I am Ariana Littleton, the statewide training coordinator at the Brain Injury Association of North Carolina, and you guys are going to be attending the nutrition after brain injury with Miss Jamie Smith, and I am going to let you introduce yourself.
Hey everybody, um, I'm Jamie. I live in the Raleigh, North Carolina area. I actually live in Rolesville, if anybody knows of that little town. I'm from Pennsylvania, as I said just a few minutes ago. I did my undergraduate degree at West Chester University. I did my master's degree at East Carolina University, and I have been working with people with traumatic brain injuries for 15 years. I work in post-acute care, so kind of in the outside of the hospital setting in a facility. I work at the Learning Services, which is now called Collage Rehab. They have two locations, and then I do some work for Nora Restorative in Raleigh, and then I have a dietitian that works with me at the Charlotte program for Nora Restorative. So lots of experience with brain injury care. I also work at an acute care hospital, UNC hospital, 2 days a week. So I have some inpatient experience, but most of my experience with brain injury care is after the hospital, but I'm going to be including some, brief information about what happens in the hospital in case you are curious what happened to you or to the people that you work with or your loved ones. So I am going to share my screen. Host disabled participant screen sharing. We should have thought about that. Oh no. Okay.
Were you able to share it? I'm sorry.
No, it's saying host disabled.
Okay, give me 1 second.
Sure.
We already fixed this glitch, but okay, give it a try now.
Okay. Good job.
Good to go. I wanted to mention while Jamie is presenting, if you have any questions, please feel free to drop them inside of the chat box and I'll be monitoring them. And I'm sorry, not the chat box, the Q&A box, and I'll be monitoring them and I'll let Jamie know when there's a question.
Yes, I'm sorry. I forgot to mention that.
No
I
worries.
did put two spots and then of course the end for questions. But there are 2 spots I left for questions, kind of chunked it based on the topic. But feel free to type in your questions. I'm a kind of person that forgets the question. So feel free to type in the question ahead of time if you have it. Okay, so nutrition after a brain injury. Just a brief overview about brain injuries. If you're not familiar, a brain injury is caused by an external force up to the head. About 2 million people in the US sustain a brain injury every year. 5 million Americans are currently living with a disability from a brain injury. And even people with mild TBIs are at risk for neurological and cognitive symptoms. I've seen people with very mild concussions or didn't even think they had a brain injury have long-lasting cognitive deficits. And then people with very severe brain injuries have very little long-term. So it's such a wide variety as you may have experienced. And I'm going to use the word TBI often instead of traumatic brain injury. Common causes, mostly falls, and motor vehicle accidents, people struck, assaults, and then other unknown, sports injuries, that sort of thing. But most people that are at risk are children ages 0 to 9, and then adults over the age of 65. I do not work with anyone with any children. I have not had any children with TBIs, so I don't have personal experience there. And the highest rates of death are in people aged over the age of 75. And more males are likely to develop TBIs. And there's probably a lot of different reasons, but in my experience, it's just that most brain injuries that I have worked with are people who were injured at work or in a car. And so I just think men tend to work in more often work in physical jobs that puts them at a higher risk. Some of the brain injury complications that you may have experienced or seen, I'm not going to read all of those to you. So I'm mentioning anxiety and depression because those two things can really affect nutrition for different reasons. Um, but some people with depression could eat more. They might binge eat or use eating as a coping mechanism. Also, some of the medications can cause increased weight, increased appetite, metabolic changes. And we do sometimes see weight loss as well, more so with people with anxiety. They might have a decreased appetite. And 70% of patients with TBIs experience anxiety. And then about 50% experience depression. In my experience, I feel like they're flipped. But that's just what I've seen. The other way, it's, half of the people have that problem. So I'm going to be breaking down the presentation, briefly talk about acute phase and the treating complications, and mostly we're going to be talking about nutrition, but I'm going to briefly go over these things with you. In the acute phase, which is when they're in the hospital trying to sustain life, right? So really the first couple of days, for the most part, people experience hypermetabolism, which is an increased metabolism or burning of calories. So their body is needing more calories to heal, recover, stay alive. And you're going to see a lot of weight loss in that period. Up to 15% of their body weight per week can occur. Now, this period can last a lot longer. It can last up to months. I've seen a few people who've been in this state for up to 6 months. And these were people who were severely impaired, having something called central storming, where their body is just metabolic, needing 3,000 to 4,000 calories a day. For the most part, it's just a couple of weeks. Early feeding, and when I say feeding, that can be oral feeding, but typically it's going to be through a tube or an IV, is really essential to prevent catabolic stress. That means catabolic is when your body's breaking down. If you're not getting nutrition, your body's going to be using itself for fuel, taking away fat stores, the minimal glucose stores that you have, and muscle and fat and glucose. And we don't want that. It's going to make you weaker. It's going to make you have more problems, all that. And you have a 4-time higher increase in mortality when someone is not fed within 7 days. Dietitians are on board with people in the ICU setting. They follow everybody in the ICU. They are pushing for feeding as quickly as possible, as the doctors will allow. We try to do NG tubes, which are nasal gastric tubes, little tubes that go up the nose, go into the stomach. There are times when those are not able to happen. Perhaps there's a stomach injury or an abdominal injury in addition to their brain injury. They could have facial fractures. They might need facial surgeries. So sometimes a nasal tube isn't appropriate. And there are times when a tube directly into the stomach, typically called a G tube or a PEG tube. So sometimes we have to do nutrition in the vein. And this is referred to as TPN, total parenteral nutrition. And a dietitian is going to be monitoring that patient during that time to make sure they're getting everything proper. And then regardless of all of what I just said, people still lose 15 pounds on average during an acute hospitalization. I work in an acute care hospital. I would say about 10% body weight is lost unless it's just like a day or two, but that's very, very common because of that hypermetabolism. And if you've ever been in the hospital or had somebody in the hospital, there's times where they have to be NPO, which means nothing by mouth, for testing. So then there's periods where they're not able to get any nutrition because of testing. The things dietitians are going to be looking at, fluid and electrolyte abnormalities. This is very close monitoring and adjustment of nutrients to make sure that the patient is as stable as possible. You also need to monitor how many calories are being taken in to prevent overnutrition. It can cause issues with high blood sugars, fatty liver, and then it's too much on your lungs if you get too much nutrition. And in a situation in the ICU, people typically are on a ventilator or need oxygen support. So you don't want to give too many carbohydrates to increase the work of the lungs. And then we have to keep an eye on the feeding tube. There can be a lot of complications, issues with where it's going, having it dislodged, having a patient pull it out, intolerance. Intolerance is typically vomiting or diarrhea or constipation. I had a patient yesterday. She's not a brain injury patient, but her tube feedings were not going anywhere. So she wasn't digesting them. They just sat in her stomach. So that happens at times as well. And then we have to figure out and fix that problem. Protein is really essential because, like I said, if you're not getting that protein in every day, your body's using its muscles. So, and in the brain injury patient, up to 2.5 times needs compared to a normal person. So you need a lot of protein. Protein is typically added into the tube feeding separately. So those first two pictures, Prostat and Promod, they're liquid. They can be given by mouth or by tube. And we use those a lot in the acute care setting to bump up the protein. And then those other two are powder and like a Ensure high protein that we would use once somebody gets back on an oral diet, or you can consume those at home. And the dietitians are going to be monitoring the protein needs and the protein status. There's a lot of different labs and a lot of different ways that we manage that. And in terms of glucose, blood sugar, hyperglycemia, which means high blood sugar, is going to be common in any trauma patient. So not just brain injuries. So anyone that's been in any sort of major issue, someone had surgery, people's blood sugars are going to be high. Blood sugars are going to be monitored, usually 4 times a day. Insulin will be given to decrease that blood sugar back down. That doesn't mean they have diabetes. It doesn't mean they're going to develop diabetes. It's just what happens to the body in trauma. But we have to monitor those things because too high of blood sugar is going to decrease or increase the poor outcomes associated with their care. There's going to be negative neurologic outcomes. And the brain injury severity can be worsened with hyperglycemia, meaning high blood sugars. And that little chart, that just has normal blood sugar ranges. Fasting, meaning not eating, and then what they are if you ate, and then a couple hours after eating. So typically those are in the, they can be in the 200s and 300s, despite not getting any nutrition in a patient with trauma. So those are closely monitored. Fat. So our brain is 60% lipids. And so our body needs to get fat for our brain to work properly. And this is actually important long term. But in the acute care setting, in the hospital setting, the tube feeding formulas that we use are supplemented with DHA. It's anti-inflammatory and it might help prevent traumatic axonal injury. A lot of those nutrition supplements that I showed, the Ensure, those all are supplemented with omega-3s as well. So a quick wrap up. Early initiation of feeding is essential. Get that person started on nutrition as soon as we can. Realize hypermetabolism can last weeks to months, months being more on the rare side. Extra protein and fat are necessary, and limited carbs is also something that we are going to keep an eye on to prevent that hyperglycemia. So this is a stopping point. If anybody had any questions about that, this would be a great time to ask them. And has anyone asked any questions about that yet?
If you would like to verbally ask your question, all you have to do is raise your hand and I can allow you to go ahead and ask your question that way. But I had a question about something that you had mentioned, if that's okay with you. You mentioned in the acute phase that they tend to lose a lot of weight. And you may come up had the answer later on, but my question was how do you like regulate that weight loss during the recovery phase once you're out of the acute phase?
How do you regulate weight regain or
Well,
you
I guess I'm asking how does that affect the patient when they're recovering?
oh yeah, it definitely affects them. They become weaker. Um, and they need, they're going to be getting physical therapy. They're going to be weak from being in a hospital bed. In terms of research on weight loss and outcomes, I don't have any of that information. Um, but yeah, that's any weight loss is going to have muscle loss. Any muscle loss is going to make recovery harder because you're going to have to rework all those muscles and regain them all back. So the more weight loss, you know, the the worse it is, I'm not sure if that answered exactly what you were asking.
No, that was wonderful. Thank you. I
Okay.
appreciate that.
Okay. All right. I'm going to close that box. Okay. We're going to move on if I can figure out how. Okay. Um, post-acute care. So a lot of things that we see, you guys might have experienced. Behavior issues around eating. So a lot of people have impulsivity. Um, a lot of it is seen at mealtime with how someone may be eating. They might be cramming food in their mouth very quickly, not chewing as long as they should, or continuing to put more food in before, the last bite's taken, taking too large of bites. You also have people who are searching or stealing food. That happens a lot. And then behaviors, acting out, specific food requests, wanting more food. That is common. I have several patients over the years who will finish eating a meal and maybe often the ones I'm thinking of are in a wheelchair. They'll be moved to a different area and then immediately will ask, when are we going to eat? And you just have to there's different options we can do to help manage that and help redirect them. But some people are not going to remember. They have that short-term memory loss. They don't remember that they just ate. They might not remember to eat. So they need a lot of structure and scheduling in their day to help get a routine for them. And of course, they're going to thrive on a routine. I even have a patient right now. He's been a patient of mine for a couple of years. He's gained 100 pounds. He lost 100 pounds during his injury, and then he's regained 100 pounds. And the 100-pound regain was in about a year. And he will be eating with food in his mouth and will ask, "What are we going to eat?" It's just constant. It's constant. It's like, he's very impaired. And there's a lot of different things we set up for him to help minimize the obsession with eating. Did I skip a page? Okay, no. We also see a difficulty chewing or swallowing. That's called dysphagia. The person may require an altered diet texture, like a puree diet or like a mechanical soft diet. And this is something that a speech therapist is going to assess through different studies, different swallowing studies. So this is not something that a dietitian per se prescribes, but they would help. Like I help make menus for those people. I help educate the staff on knowing what foods they can and cannot have. And then their liquids may need to be thickened so that they don't choke. And they might need cues and prompts during the mealtime to say, take your time, take up one bite at a time. Some people don't love being told what to do during a meal, so you really got to be careful and try different things to see what words work. Some people with dysphagia have a hard time taking solid food and swallowing it, but they do very well swallowing liquids. So often people are educated and encouraged to, after you take a bite, take a sip and it's usually via straw. So usually straw sip, and that helps them to automatically swallow their food. And for these people, you're going to want to monitor the signs of aspiration, such as coughing, difficulty breathing, wheezing, fast breath, shortness of breath, any breath issues after a meal. You really want to think about it could be that they aspirated, and aspiration means food going into the lungs. Coughing isn't necessarily meaning that they aspirated. It could be a good thing, and sometimes you actually want to encourage coughing because coughing is going to get the food up above, so the coughing, of course, food gets it out. So it's more of like this excessive coughing. Some people are actually told to do a throat clear cough, which would be like that sort of thing can really help to get the food out of the way. And then some people need enteral nutrition, which is tube feedings long term. I would say I have a handful of long-term tube feeding patients. And you know what? Every couple of years, we do still check their swallowing function unless it's extremely detrimental for them to have a swallow study completion. So we have a guy who can't even attempt a swallow. So we don't do his swallow study every couple of years, but we have a guy right now who has been on a feeding tube for over 10 years. He's been NPO, nothing by mouth, and speech therapy has worked with him. They've done a swallow study, and he now is able to have like a small meal and a small snack every day in addition to his tube feedings. And so we just kind of adjusted and decreased his tube feedings a little bit so that he can, not be overly full. And it's great. So if, something to consider if you have someone that's been on a feeding tube for a long time, and you should probably request a speech eval, and the speech therapist could recommend what type of swallow eval they may need. So tackling weight gain after a TBI is difficult. It's a very common job function for me, is people gain weight. They are probably not as active after this is after their injury. Once they're more stable, they're not doing therapies anymore. They're not as able, they're in a wheelchair, or they have some other difficulty walking, or they can't run, they can't lift weights. So they're going to be gaining weight. They don't have that ability to stop eating their medications. So weight gain is very common. So what we do is we have to really limit access to foods. Depending on the situation of where they live, you may need to have a kitchen that is locked, having refrigerators that are locked, having cabinets that are locked. It's not in every setting, and it's just a couple of places that I work at that are in that situation. And if it's not locked, we have like a snack area, kind of like a pantry, and the people have their own snacks in each bin, and that area there's a staff member working in that, so they can observe and make sure that the person is not eating all of their snacks. I've had a patient who will eat a whole loaf of bread, and just have to kind of rethink where we keep the bread, or where we keep things that he tends to overeat. So really structuring the environment. Some people need pictures of what they eat. They don't believe you when you said you just ate, so you'll take a picture of the person eating, and you should, like, when you just ate. Depending on the person, you could do a food journal. They could do a food journal or an app that does the food journal for you. This is also helpful if someone is trying to lose weight. Food journaling and food journaling apps are really great to kind of get them to sort of see how much they're eating, and it tells you how many calories are in the food. And they're free apps that you can find. Scheduling meals, scheduling activities, and redirection are crucial with people who are constantly asking for food. We've all experienced boredom in life, and we often will eat. Like, I'm not really hungry, but I'm bored and food's here, I'm going to eat. Well, this is very common with people with TBIs. They might not be working anymore. I mean, the people that I'm thinking of they're not working. They're not able to perform household tasks, so they're bored. So creating activities, often we try to do something right after a meal. So, let's say 9 to 10, there's an activity. And then right after lunch from like 1 to 2, there's an activity. And then I try to do like a walk. We try to do a walking group, or like a mobility group after a meal as well. And then redirection, knowing what they like to do and offering an alternative activity. If they like to read magazines or do puzzles or play dominoes, redirecting their thoughts to something else. Medications can cause weight gain. A lot of TBI patients are on some of these medications: antidepressants, and seizure medications, mood stabilizers, antipsychotics. Antidepressants don't really cause too much weight gain. It's usually like 5 or 10 pounds. It doesn't continue forever and ever. But antipsychotics, mood stablers like Seroquel, Risperdal, Abilify, Zyprexa, those are the common offenders for causing a lot of weight gain. And then high blood pressure, high cholesterol, and you can develop diabetes from those medications. So we're working against that as well. So in addition to, the actual brain injury and the impairment in the body, you have these medications that are increasing your appetite and weight. And some of these medications, specifically Zyprexa, can actually cause weight gain 2 years after stopping the medication. That's the biggest offender in terms of weight gain is Zyprexa. And then stimulants like medicine for ADHD that you might have heard of, Adderall, Vistaril, Concerta, those are going to decrease your appetite. And I have one patient that's on those, and we have to give him extra portions. He gets nutrition supplements. He gets 2 breakfasts, and he still struggles to keep his weight up. So that does happen, but it's more rare. Additional concerns that may happen are going to be an altered sense of taste and smell. I don't see this often, but it's in the literature, and I've seen it a few times, where they can't taste or things taste bad. Now, a lot of us have been seeing this more often with COVID. And I experienced this personally, and I did aromatherapy on myself, and you can just Google that if you have anyone with this. But you get a couple essential oils, you sniff them for 10 seconds, take a break, pick another one, and it kind of rebuilds your smell. And it worked. Everything for me tasted like pepper. It was horrible. I people that have this long term, it's got to be just the worst thing. I couldn't. It made me sick. Just the smell. Just sitting here, I could smell it. It was rough. Changes in bowel movements and just the digestion in general. So it can be from medications, and it can be just from changing them being an active person to now being less active and potentially in a wheelchair. It's going to cause issues with your bowels slowing down. Most people are on stool softeners or laxatives. Acid reflux, you have a higher chance of having acid reflux, so you got to keep an eye out for that. And then there's foods to avoid and foods to have for those. Of course, if you have constipation, you're going to want to increase fruits and vegetables and fluid. Acid reflux, you are going to want to avoid acidic foods, caffeine, carbonated beverages, alcohol, which people with brain injury should not be consuming alcohol anyways. We talked about weight gain. And then weight gain can cause additional chronic diseases such as diabetes, high blood pressure, high cholesterol. So I have worked at the programs, learning services for 15 years, and I've had a few people develop all of those. high blood pressure, high cholesterol, diabetes as a result of weight gain and medications. And so now we're having to keep an eye on that. I recommend everybody have annual lab work done. That includes a cholesterol panel and your hemoglobin A1C, which looks at diabetes. We all should be doing that, but really we should be doing that for people who've had brain injuries. On to nutrition components, calories. So protein is essential. We all need protein, and we need it for our building blocks for neurotransmitters in your brain. Antidepressants aren't going to work if you don't have protein, because protein is the building block of serotonin. So making sure that somebody's getting protein 3 times a day and or with every meal. No more than 30 grams of protein at a time. The body cannot utilize more than that at once. So having protein drinks that have 60 grams of protein, it's better to split that up. It's not doing you any service to have all of that at once. It's really best to split it up throughout the day. Here are sources of protein. You know, typically it's going to be meats, dairy, and then beans. Most foods have a little bit of protein. There are plenty of vegans and vegetarians that are going to get adequate protein. Just takes a little bit more planning. But as you can see, there are some vegetables on here. Carbohydrates, this is our body's main energy source. Carbohydrates are found in sugars, starches, and fibers that are in grains, vegetables, and fruits. And dairy products, we should be getting all of these food groups, but limiting sugars like desserts, candy, soda, juice, sweet tea. So carbs are not bad. Carbs are great, but you know, carbs from honey buns are not great. Carbs from bananas and berries would be a better choice. We should be aiming for 3 servings of vegetables a day and 2 servings of fruits. Those should be varied throughout the course of a week. It's not always possible. Somebody might only like bananas and apples. A banana and apple is better than no fruit. But if someone is not picky, then, you know, altering the colors is a good way of doing it, because the different colors have different vitamins, minerals, and antioxidants. Fat, we talked about fat earlier, but it is essential and necessary and helps to absorb those vitamins that are fat soluble, which is A, D, E, and K. Fat is very dense. It's almost triple in calories compared to the same volume of protein and carbohydrates. So it's 9 grams of 9 calories per gram, where the other 2 are 4. Anyways, it's just very dense. So it's filling in that way. It's just to be mindful that it is very caloric. And we need to be limiting saturated fats and trans fats. Those 2 are the bad kind, and they're going to raise your bad cholesterol. And on the next slide, I have what those are. So in the green, those are the good ones. Those are mostly from plants and fish. So polyunsaturated is necessary. We need it. It comes from, most people get it in cooking oils and nuts and fish. And then monounsaturated, again, they're in like avocado and nut butters. And then the bad, like the really bad, is that red trans fat. It has been banned by the FDA starting in 2018. But those are things that, like the have you heard of the partially hydrogenated? That's a trans fat. So the like in honey buns and the things that are in packages on the shelf, that's going to have trans fats. Those should really be avoided. Saturated fat is something that you need to limit to less than 20 grams per day, but you can have 0. That's even better. So that's going to be in animal fats and coconut and butter. So if you think about fat that's solid at room temperature, that's the bad kind. It's an easy way to think of it. Caffeine often needs to be avoided or really limited. In my programs, we try to cut it off at noon. So any coffee after noon needs to be decaf. And then we limit caffeinated beverages outside of coffee to like one a day. And in general, we all should have 400 milligrams or less. That's considered safe for humans. Anything more is not safe. And you can, as you can see in that diagram, 400 milligrams of caffeine it's a moderate amount. It's not just one cup of coffee. You can have, you know, 5 smaller coffees, and that's I'm not saying we should, but that's the limit. It interferes with sleep and appetite. I have people at the psych hospital I work at, they don't limit caffeine and they can't they can't sleep at night, and then they're on sleep medications, and then they're tired in the morning, and then they drink caffeine all day, and then the cycle continues and continues. So one of the things we look at is if someone that's having bad sleep is, are you having any caffeine, and educating on reducing that caffeine. It's also a, you know, a stimulant, and it can affect medications, your heart, and increase anxiety. So caffeine is something you really need to look at and consider if you're having some of those problems. Exercise is beneficial for the brain. It improves neuronal functioning during and after exercise. You should obtain physical activity approval by a physician, and the physician may or may not recommend you see a physical therapist who may prescribe an individual home exercise program. How much exercise do we need? This slide here is just for everybody. This is general American recommendations for exercise, and it's 150 minutes of moderate exercise a week. And it should be in 10-minute increments or more. So that 10 minutes is crucial for your cardiovascular benefits. It's recommended that you do some yoga or like weight training a couple of times a week. This is not possible for everybody. But for those that it's possible, this is what we should aim for. And then decreasing sedentary time for long periods is great. So if the person that you are or that you work with is able to be ambulatory, encouraging frequent things for them to do, you know, just depending on the situation, is going to be helpful for their health. Brief nutritious diet for brain injuries. Overview we just talked about. Well-balanced diet rich in fruits, vegetables, and whole grains. Limited saturated fats, trans fats, and sodium. I didn't talk about sodium, but sodium should be monitored and limited. Ensuring a variety of foods. So, you know, not the same foods all the time, so that people are more likely to get all the vitamins and minerals. We should be limiting caffeine and encouraging daily exercise. Now, the next section, I'm going to be going into more detail of specific diet and supplements, but I wanted to leave room for any basic nutrition questions about anything I just spoke about. So feel free.
2 questions inside of the question and answer box. The first one, would you like me to read it to you?
Yes.
Okay, so it says regarding tube feeds, does the medical team vary/test the feeding schedule and method? For example, pump feedings overnight versus push syringe feedings at regular intervals during daytime hours.
Okay, great question. We are always going to start with continuous in an ICU type setting. It's just easy for the body when they're under a lot of stress. So typically that's where it starts. And then depending on the situation, the goal is that bolus feeding, which is like the push syringe. So we would like to get everyone to that situation because that's more like what our body's used to. We're not used to eating 24 hours a day, small amounts. So we try to do the bolus. Often patients are moved around before we can trial bolus feedings in the hospital setting. It's more of like a rehab adjustment. there are times when a patient is appropriate to start right off at bolus feedings, which is those mealtime, like, give 1 carton or 2 cartons at a time. So that would be somebody who is more ambulatory, more alert and oriented, kind of healthier. They can usually start off with bolus feedings. And we like to see tolerance of those for 2 days before they discharge somewhere else. That's what I like. So when someone's coming into the programs that I work at and they've been on continuous feedings, which we don't accept, I would like, and I kind of require, they need to tolerate bolus feedings for 48 hours before coming to our program.
Thank you for that. These are
Mhm.
wonderful questions. I have some more.
Mhm.
The next question is regarding facility PT and constipation mobility. Do patients have access to adult-sized standards, gait trainings, water therapy, where safe and appropriate?
I might have to read that question. Sorry. How can I find it? Okay. All right. I'm looking at the question now. Yeah, so we do have so gait trainers. So gait trainers are going to be when someone is not really able to stand up on their own. There's different devices, and I'm not overly familiar with the correct terminology, but in general, they're gait trainers that gets their body kind of standing in an upright position, which is awesome to help their bowels move. I'm not sure about water therapy and what that really means, so I'm not sure about that. I'm sorry. And have access to adult size standards. I don't know what that is either. Okay. And then I'm looking at the next question Stacy had. Do you recommend any particular brain diets propagated in the media? Okay, yeah, so I'll be talking about those diets next, Stacy. And recommend taking multivitamins. Molly, I'm going to get to that next. So yeah, I'll be, and Stacy, if you have more specific questions about that, the PT, we can talk offline about that. But our the programs I work at do have physical therapists, and sometimes we train them on people who have, these are more for spinal cord injuries, people who have neurogenic bowel, meaning their bowel just, they can't tell when they have to have a bowel movement. They might have to do various bowel programs, but one thing we like to do is where you massage your stomach kind of in a clockwork around your abdomen, following your large intestine into circular motions to help stimulate moving the bowel around. Okay, so I'm going to get moving to the next question, the next section before time is up.
Jamie, can I ask a question really quick? I also
Yeah.
have a question about some of the foods that were in suggestions. Like, what if a person living with a TBI were to have also like diabetes, and the fruit, like when they eat fruit, they have natural sugars. How do you
Mhm.
suggest they regulate eating lots of fruit, but also making sure that they maintain a healthy sugar level? I guess that's how we put it.
Yeah, I encourage fruits. Dietitians encourage fruit. Most people should be having, with diabetes, about on average, 4 carb servings per meal. It can be 3 for smaller people and 5 for bigger people. And you can certainly, the fruit would be, now bananas, some of the bananas are humongous, and that could be 2 servings of fruits. But you can certainly have fruit when you have diabetes, and you should. They have fiber, and they can be also as a snack. There are rarely the people who overeat fruit. I don't know of anyone that does, but people tend to overeat more of the sugary sweet stuff versus like having 4 bananas at once. But we do try to limit the amount of fruits at a time, because like I said, it can, if you're like a binger on fruit, it can get out of control. Okay, I'm going to get going on to the next section.
Thank you.
You're welcome. Omega-3s, you can supplement this. I'm going to kind of go through these quickly because I know we're a little bit short on time, or I'm running out of time. So you can supplement omega-3s. It's really great to do that, especially if you're someone who doesn't like to eat fish. I don't recommend certain brands. I do like Nordic Naturals though, in terms of fish oils. That's a great one. And 2 to 6 grams a day are safe. Vitamin D deficiency is very common. I would recommend you get lab work, and then the doctor tells you how much to have, but these are common amounts that I would see. The 5,000 is going to be somebody who's super depleted in vitamin D. Certain medications can cause vitamin D deficiency, specifically some of the anti-seizure medications. And toxicity can occur because it's a fat-soluble vitamin. These are some other supplements that might be beneficial: vitamin C, resveratrol. The ones with the stars, I would suggest you talk to your doctor about because they could interfere with medication. So I'm not saying you should be giving these, but check with your doctor first. But these are mostly going to help overall with cognitive function, concentration, memory, slowing cognitive decline. Lion's mane mushrooms. This is pretty popular right now anyways, but that's a great one. B vitamins. If you're taking a multivitamin, which I do recommend people do, why not? It's just in case. B vitamins are water soluble, so they're not going to build up into your body. And those 3, B6, B9, B12, if deficient, can cause potentially cognitive decline. So supplementing B vitamins is safe for everybody. Taking magnesium, there's been some studies showing that there's an increased low levels can cause an increased risk of dementia. And then ashwagandha can increase memory, focus, and stress. So those are specifically for like cognitive supplements. The MIND diet. This is the diet I recommend for people with brain injuries. It was initially for people with dementia, but it really helps with cognitive and decline. It's generally healthy. It's high in fiber, high in antioxidants. It's low in fat, low in saturated, like everything we talked about. It has, and it also is going to aid in the prevention and management of additional chronic diseases. So I'm going to scan through these. 1 to 2 servings of leafy greens a day. This can be 1 serving is 1 cup raw, 1/2 cup cooked. Put things in a smoothie. You can put spinach in an omelet. You can put it in soup. Have a salad every day. 1 to 2 servings of other vegetables per day. Others, anything else. So a variety. Those are just a few examples. So again, 1 cup raw or 1/2 cup cooked. And this is a different one, berries. 4 to 5 servings per week of berries. So 1/2 cup is a serving. Throw it in a smoothie, put it in your oatmeal, have it as a snack with some nuts. Berries should have at least 4 times a week. Whole grains, 3 servings of whole grains a day. Whole grain, 1 piece of bread, 1/2 cup of rice or oatmeal. Those are examples of whole grains there. Oatmeal is a good one for breakfast with some berries and some nuts, I think is great, and maybe a piece of fruit in addition to that. Nuts. Nuts is another one you should be having every day. 1/3 of a cup, whatever nut, doesn't matter. This is what 1/3 a cup looks like. So you can get an idea. It's not a whole lot. A shot glass full is kind of just a little bitty handful. It's easy. It's a great snack. Doesn't get mushy, doesn't go bad. Put it in the fridge. So love it. Lentils and beans. That's also kind of different for diets. It's not something that is specifically in a lot of diets. But you should have, I say, every other day to make it easy. Soups is an easy way to do it. Having Mexican night with black beans or pinto beans, hummus, fish, 2 servings of fish per week. Those are the fish that are the best in the good fats. 3 ounces is about the size of a deck of cards, so it's not like a huge amount of fish. Sorry. Poultry, at least 3 servings a week of poultry. Protein is better, if not just as good as red meat. It's of course leaner. Poultry would be chicken and turkey. And these are the things you should limit. So if you're having all that other stuff we just talked about, you're going to have to limit some of this stuff naturally because you're just not going to have enough room for it in your diet. But I would think you would all agree that these are not healthy for anybody. But limiting butter and margarine to 1 tablespoon a day. Limiting pastry and sweets to 1 serving a day or less, or less. You don't have to have this. This is the most. Red meat to 4 servings per week or less. Whole fat cheese. This is huge because a lot of people love cheese. 1 time a week. And fried fast food, no more than 1 time a week. Weight maintenance and prevention of further weight gain can be challenging, as we talked about. Weight loss plans and diets for some people can be unrealistic. I have had people who families either they gotta lose weight. It's not often realistic for someone to lose a lot of weight with brain injuries. It's just not going to happen. So it's really making sure that they're doing the healthy things. If you're doing the healthy things, you should be healthier, right? And, you know, kind of counteracting the risk factor of being obese is you're having the healthy things like the food and the daily exercise. And then just keeping an eye on those chronic diseases with those annual blood draws to check for diabetes and high cholesterol. And then you have a quick handle on it. You can change the diet more, or at least you have, I say, ammunition to give someone the reinforce, okay, you're getting close to having diabetes. You really need to take this seriously. So it's good to have those as well. Okay. Sorry, I really rushed through that. I know that might have been people's most questions that they have, but you can certainly, I'm going to unshare my screen. You can certainly Google Mind Diet, MIND, and find out, print articles and examples. What other questions did you guys have?
If you have any questions that you would like to ask verbally, please just press raise hand and I will give you access to ask those questions. If not, feel free to now drop them inside of the question and answer section of the chat, well, the box, and we will check them out. That was a lot of wonderful information, Jamie.
It's a lot, hopefully not too much.
No, that was fantastic. I am interested myself in checking out the Mind diet. So I was taking notes, writing down some things. So yes, we are going to give them a couple seconds to ask any more questions. I have a boatload of questions, but I want to give everybody else a chance to ask some questions.
There is one in there from Kristen.
There is a question, are most dietitians trained in conditions like TBI, or is it a specialized topic?
No. So in dietetics, we have to do a clinical rotation of about 4 to 6 months, and we might be exposed to TBIs. I was not. So I just kind of learned along the way. So there's no training program that I've ever been a part of. So it's just experience, I would say. And I was a certified brain injury specialist at one point. I didn't keep up with my CEUs, but I do keep up with I work in it almost every day. So I do learn a lot. I still learn a lot about things, as we all do.
We have another question. Do you ever encourage muscle building supplements like, and I believe it's pronounced creatine, Creatine?
Yeah. I haven't had anybody that's really, I'm familiar with creatine, and there's some science about it can be helpful, and it does help to build protein. I don't have anybody who is building a lot of muscle and doing the physical work to build like bodybuilders. So I have had a few people who've who've wanted protein powders, and they did include creatine, and I think that's great, but I don't specifically, I don't often have that.
Okay, and there's another one. This is a question aimed at the slides. This recording will be available on YouTube, so please just check back, and I'll get them up as soon as possible. And we will be emailing this out as well. Another question is, do you recommend, and I do not know how to pronounce this one, a ketogenic diet for survivors experiencing intractable seizures that is outside the scope of this talk, but they were just curious if you had.
Yeah. Sorry, I see it now. Yeah, I pulled
Yeah.
it up. I'm sitting in front of a desktop and I kept using my mouse and I'm like, what am I doing?
No.
So I have never had anybody that has had intractable seizures that's been appropriate for ketogenic diet. I do have a friend whose son is on a ketogenic diet, and we've kind of collaborated, and she actually makes all of his tube feedings, and she uses coconut oil as the liquid, or coconut milk. And she has had success. So he is on a vegan, but it's vegan ketogenic. But yeah, there is science that someone with ketogenic diet does reduce their seizures. The TBIs I've seen, the seizures have never been that severe. I guess I've seen that's more so in my mind, someone with like a specific epilepsy or like another medical condition, but not TBI.
Another question we had about CEUs. We are not currently doing it for this particular webinar, but we are looking forward to offering them soon. So, and then somebody said, thank you and happy Tube Feeding Awareness Week.
All right, I didn't even know.
I didn't either. So thank you for letting us know.
Yeah, thank you.
About that.
Yeah.
It is real. I just looked it up.
Nice. Very cool. Any more questions? Please feel free before the time is wrapping up. Please drop them in the Q&A box, and we will get to them. I want to give them another minute to ask questions.
Sure.
But while we wait, I would like to ask a question.
Yeah.
Really into this. Was a wonderful presentation. So I want to thank you first of all for providing all that helpful information. And I think when I was looking, you mentioned something about like, oh, are there foods that you suggest to like curb appetites? You know, people who like tend to overeat or like eat out of boredom. What food do you suggest to curb appetites?
Protein, fiber.
Okay.
Yeah. And then of course, increasing fluid, having fluid starting like before your meal can help with your stomach, but it's not going to curb appetite. Protein is going to stay in your stomach longer. People on high protein diets, are rarely hungry. And what I've been told by the people on those diets. So a lot of protein. But you got to be careful because you can have kidney issues and and high protein can be high fat, which you can have cardiovascular. So some people I have on like large or double protein portions at their meals if they are hungry often, and all those, they don't have any of those other risk factors.
Well, I think that is it. Oh, wait, we have one more question. Can diet and supplements help prolong cognitive issues even 1 through 2 years after injury? And that will be our last question for the webinar.
I would say yes, absolutely. Yeah, you want to slow that. I mean, so some of the people I've worked with at my programs have had brain injuries for decades, and they have developed, let's say, Parkinson's or cancer, or those are the main ones I'm thinking of. No one's actually developed dementia, but they rapidly progress in those diseases much quicker than anybody else that I've seen in regular life, not not with a brain injury. So I would say yes to support the cognitive function long term, because yeah, you want to preserve it. I mean, it can prevent dementia, and if they get dementia, I would estimate it's going to very rapidly progress compared to someone without a TBI.
Well, thank you so much, Jamie. And I want to also thank you all for attending this wonderful webinar. Please feel free to visit our website where you can find more webinars that we are offering, a chance to register, and also where you can feel free to donate. If you go onto the website and you click at the top, there will be a button at the top that you can donate. There is also a link inside of the chat box at the end of the webinar. When I end it, there will be a survey that pops up. Please, 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 please provide your feedback on how fantastic Jamie was and how you loved the webinar, because I absolutely loved it. And I want to thank you again, Jamie, for your
Yeah.
time, your information, and I will hopefully see you all soon again for our next webinar.
Bye, guys. Thank you.
Thank you.